Hello, everyone. Welcome to another Rafael Medina subspecialty virtual morning report. Really excited for today's session. Our very own Kirtan invited Dr. Dhaliwal for a case discussion. Gurpreet, if I can call you that for today. If you don't know Gurpreet, you should look up Gurpreet and watch his discussions all over the country. He's been called Dr. House. I don't know if he likes that nickname. Like we like Dr. House. He's probably kinder. Uh, and Gurpreet, just to hear from you, like how are you doing? Maybe if you want to share, how did you end up in clinical reasoning?
Yeah, well, I'm doing great. Coming to the end of the year, this is a great way to finish the year. Things sort of slow down this time of year at work and things like this. So it's really nice to actually have space in the schedule to do something like this. My interest in clinical reasoning is quite straightforward. When I was a resident, I looked around at the clinicians who I really admired in terms of how they were so good at making diagnostic and therapeutic selections. And although they were good, they weren't able to tell me how they got good. They just said things like you should see a lot of patients or you should read a lot. But even when I was that young, I knew that didn't make sense because all doctors see a lot of patients and all doctors read a lot. That's how we got there in the first place. So I became interested in what are the habits it would take to become good at that thing, although I didn't know what that thing was. And then I learned that there's a field called clinical reasoning that was being studied. So when I was able to merge the ideas of the expertise world, which really just means like maximal personal improvement, and then the clinical reasoning world, which said there's these steps, I said, well, this is a path that I could follow. And it's been very fulfilling, both for my patients, for my students and residents, and then truthfully for myself too. Always in learning mode, I think, is the key lesson of that entire enterprise.
That sounds amazing. You should write it into a book one day, maybe.
That's a
Yeah.
lot of work to write a book. I like reading books much more. I got a whole stack of them behind me.
Kirtan, do you want to introduce yourself? Say a word as well.
Perfect. Thank you so much. Firstly, I wanted to say that Dr. Dhaliwal is always very busy. So I'm glad that he made time for us so that we can learn from him. And always imagine that if you're going to meet a celebrity or who you are a big fan of, how do you feel? So same way with me that I'm having like palpitations. I texted like so many of our team members in the morning that I'm getting goosebumps. How am I going to present? It's just that excitement and thrill, which is so like precious, right? Because like different things excite different people, but meeting someone who is like a very good figure in the clinical reasoning, so we are so lucky to have him here. And one more kind of thing which I will say is that, and I know this because I have met Dr. Dhaliwal, that there are two things which are common between us. So one is that Dr. Dhaliwal also loves NEJM case records as much as I do, that
Right.
we do this religiously, right? And second is like I like to eat sweets. Dr. Dhaliwal also like to eat sweets. So I feel like that, well, if Dr. Dhaliwal is eating sweets, I should also eat sweets. Why should I worry about diabetes or whatever, right? I mean, he is eating it, right? So it's kind of like my way of justifying, right? So I'm so glad that he's here. And as always, it's the Christmas. So we like to keep it like Christmas themed. We will give it a fancy title and everything. And I wanted to thank like Aaron for helping with the scribing today, Manaswini for teaching points. And whenever you are ready, Dr. Dhaliwal, we can get started.
Yeah, let's do it. And Kirtan, both points are true. I am still reading the NEJM CPC and CPS every week. Now my streak is since January 1997, right? Every week without fail, read it, scribe it, learn. And then you're absolutely right. I still love sweets. In fact, when I do cases like this, I usually have some sweets before I start, almost as an excuse, like the brain needs glucose. We have a whole tin of Christmas sweets, as you can imagine, upstairs, and I treated myself before I came here. Any excuse.
I know, right? Same. I also had the ice cream just before this case. I'm like, I need to have ice cream.
Midday ice
But
cream is nice, yeah.
yeah. Perfect. All right. So let's get started with first aliquot. So the title of the case is the M-leaf diagnosis. So here goes the first aliquot, that we have a 80-year-old lady, 8080, who is presenting with 2 months of postprandial abdominal pain, nausea, vomiting, and 20 pounds of weight loss. She was in relatively baseline state of health about 2 months ago when all of this started, and it has been gradually progressing. She describes the abdominal pain as kind of like cramping in nature. It's moderate in intensity and it is diffuse. She cannot figure out where it is, and it stays for like maybe 30 minutes after she eats food, and then it goes away. Nausea and vomiting also persists only for like 30 minutes after eating the food. And because of this, she is scared of eating and she has lost like about 20 pounds of weight. Review of system otherwise is negative. So no fevers, chills, night sweats, hematochezia, melena, constipation, diarrhea, no arthralgias, rashes, cough, or chest pain. Her past medical history is relevant only for hypertension and mild aortic stenosis. And for medications, she is just on amlodipine for hypertension. And I would stop there before moving on.
Okay, thank you for that presentation. I think the situation or the thing that we're really contending with is abdominal pain. Sometimes we have to decide in clinical reasoning if we put the adjective in front of it or not. As an example, sometimes you might say, like, I have a fever. Do I take the approach to fever, or do I do neutropenic fever or traveler with a fever, HIV with a fever? As a general rule, I advise holding off on the adjective until you're clear on the general framework. Abdominal pain, if we just speak to that, usually we approach with an anatomic framework. People split it up into either quadrants or ninths, which somewhat localizes to the organs in each category. We often pay specific attention to make sure acute surgical emergencies like vascular events or obstructions or perforations aren't present. Sometimes you will hear this in a mnemonic called VIPO, V-I-P-O, but really it captures that much of intra-abdominal pain is inflammation, so that's the itis. But vascular events, perforations, obstruction shouldn't be overlooked. If I was to, however, just say this is postprandial in nature, usually postprandial in nature localizes us to the proximal GI structures. That is to say, it's not that common that people eat and immediately, for instance, the colon is acting up. And so quickly, if we just did common things, you would say that perhaps this is a problem with the esophagus, like GERD. Perhaps this is a problem with the stomach, like dyspepsia, which is functional, or ulcer, which is anatomic. Perhaps the organs that are stimulated by food, like the pancreas with chronic pancreatitis, or even the biliary system, are coming into play. And those would be general thoughts. I think things that characterize this as being different is the degree with which it lasts. So it's lasting for 30 minutes and then resolves. So you're trying to think what biological processes sort of have an on-off function, and then has led to sort of essentially food fear. When you have weight loss and GI syndromes, you're oftentimes trying to decide, is the person just having weight loss because they're eating less, which might be the case here? That is to say, it's an anabolic problem. There's not enough calories going in. Or perhaps they're eating less, but they're really losing weight because there's a catabolic process that's happening there, like the cancer that is causing these symptoms. And then one thing I think this story, probably if you fed it into your brain or ChatGPT, you would recognize that it's very suggestive of mesenteric ischemia. And the elements of it is you have a person who could have this. They have risk factors like age and hypertension, and even aortic stenosis shows a predilection for atherosclerosis. They have very shared biology. And then the onset of pain after eating and then resolving as the bowel is put to rest all make me think that vascular considerations will be in play as well.
Right. Thank you so much, Dr. Dhaliwal, for that wonderful start. Now let's move to the next part regarding the patient's further clarifying the symptoms to get a sense of what's going on. She denied any kind of dysphagia, no odynophagia, and we asked specifically that what is the reason you are not eating? Is it just because of the pain or discomfort? Because that is what we think in mesenteric ischemia, right? So she was not able to pinpoint that why she is not eating. She was just saying that she has, in a way, a little bit of anorexia. That is the reason why she is not eating. And of course, abdominal pain is not helping either. So that was the story. And to give you more granular details, like how this evolved over 2 months. So nothing really changed, that the abdominal pain still stayed same in the intensity. It was not getting worse. Even her nausea and vomiting is not too worse. Like it happens maybe once or twice in a day, not more than that. The weight loss part was the reason why I was trying to probe deep, that how did you end up losing so much weight? Is it just because of not eating enough, or is it something else? And unfortunately, review of system was completely fine. I kept on asking, but we cannot find anything else. So moving on to the next part of the exam, the patient's vitals were within the normal limits. And this is throughout the hospitalization. It has always stayed normal. And so physical examination, only remarkable for generalized abdominal tenderness, which was mild in intensity, but no particular quadrant where you could elicit more. No rebound tenderness or rigidity. Just on superficial palpation, there is mild tenderness in all the quadrants. Otherwise, head and neck examination, mucosal examination, is within the normal limits. The heart and lung examination is fine. The extremity examination is also looking okay. You get some basic labs. So basic lab shows that CBC was within the normal limits. The CMP was within the normal limits initially, but over the course of like multiple hospitalization, if I had to summarize, I would say that the only thing which stood out was the albumin was slightly on the lower side. It was ranging between 2.5 to 3. Otherwise, patients AST, ALT, alkaline phosphatase, bilirubin, LDH, all within the normal limits. INR, APTT, also within the normal limits. They get the UA, just like a baseline screening UA, which was within the normal limits. They obtained the TSH, HIV, and syphilis screen, which was within the normal limits as well. And yes, I would stop there.
Okay. Can we go back and this may almost be me re-interviewing you, but I think you spent some length trying to describe that her pain wasn't painful or that wasn't the governing reason that she doesn't eat. Can you just
That's
elaborate
correct.
on?
Yes, you are right, Dr. Dhaliwal. So she told me that it's not that she is not eating because of the fear of pain, because the pain was not that terrible to her. It's just that she was having anorexia. She was
Okay.
like, I don't feel like eating at all. That was the
Yeah.
reason.
I think that gets to a teaching point. Oftentimes we have patients who are referred to us because they're not eating. And I think, that itself warrants a framework. And I think you alluded to some of it, but just to spell it out, provided people have access to food, that's to say anything from money to grocery stores to being delivered to them. If they have food in front of them and they will not eat, I think we oftentimes have to figure out what is going on. Is there anorexia? There's a lack of desire to eat. Is there dysgeusia, which in the elderly can happen for many reasons? Essentially, they've lost the taste to eat, which drives eating. If they have the taste and they can swallow, then, or sorry, if they have the taste and have the will, is there some form of dysphagia, oropharyngeal or esophageal? And then getting down to the abdominal region, which then pain and other factors start to factor in. I will say in patients who have mesenteric ischemia, oftentimes they stop reporting pain. That is to say, they have pain as an early symptom, but they eventually get accustomed to eating less and less and therefore have less pain. And then they start to have an interpretation that they are anorectic. An analogy that people may know is someone who has very bad CAD who says, no, I don't have shortness of breath, or has bad peripheral arterial disease, but says they don't have claudication. But what is confounding the picture is that they've limited their activities so that they no longer experience the thing that characterized the illness in the first place. Um, the abdominal exam, in some ways, it's helpful to know that she doesn't have a localizing finding, that she doesn't have severe tenderness, since mesenteric ischemia is being diagnosed or discussed. So it's worth mentioning that finding of pain out of proportion to exam, which we oftentimes learn about, and that is a characteristic of acute mesenteric ischemia. Now, she's not in the moment sounding like acute mesenteric ischemia. She sounds like chronic mesenteric ischemia. But it's worth noting because we learned that so often that it's a very deceptive finding. In one sense, it's true. People with acute mesenteric ischemia do have intense pain that is much worse than their abdominal exam. The tricky part is it's also one of the most reassuring findings you'll have in medicine. When patients come in with abdominal pain, we are concerned about a number of features. And if their abdominal exam is benign, 99 times out of 100, it drives us actually into a very reassuring category. And so this exam doesn't limit that possibility, but it's worth noting that her not having tenderness doesn't move it into mesenteric ischemia per se. So then the last piece I'll mention here, she has a low albumin. Albumin is a very tricky lab. We talk about it all the time, and it gets many, many things ascribed to it, which are hard to prove. One is nutrition, and the other is edema. Edema gets attributed to it because everyone learns Starling forces at school, but it's rarely the primary driver of edema. Nutrition also gets ascribed to it. In most studies, it turns out not to be a great marker of ischemia or malnutrition. It's a much better marker of inflammation, and it's negative acute phase reactant. So I think we're always on the hunt to make sure that someone doesn't have profound malnutrition, and she may be on her way there, but I'm also making sure that she's not losing albumin, either because of liver disease, which we have no evidence for, urinary losses, which the negative UA argues against, or perhaps protein losing enteropathy. I think that's a remote possibility here because we feel like there might be something in her GI tract that might be, for instance, infiltrative or malignant, like a lymphoma. But I wouldn't make too much of it now unless I had more anatomic abnormalities in the GI tract. Just pin it on that.
Love these thoughts. And Gurpreet, I just wanted to ask you, what clinical setting would you treat this patient? Are you admitting them to the inpatient setting? And what's on your wish list?
Yeah, I think the basic labs were done. I don't know if LFTs and lipase and such were done as well. You need all the basic GI labs there, so I wouldn't enumerate them, lactate and the sort. I think really the imaging, you're going to need abdominal CT, and I wouldn't waste too much time debating that. It's very hard to make progress on this. I think some people were talking about whether you do or don't get an angiogram. That has to do with particular timing. A contrast CT scan will give us a ton of information. CTA for questions like mesenteric ischemia and SMA syndrome and the sort would be helpful, and that relates to just optimizing the timing if that's your leading hypothesis right now. So I think I wouldn't need things to be more exotic than an abdominal CT at this point.
Perfect. Thank you so much, Dr. Dhaliwal. And again, friends, just to lay it out that the case might seem a little bit vague and weird as of now because there's like not much positives jumping out, but that was the case in reality as well, that she seemed completely fine, but then she kept on losing weight and otherwise her ROS is like completely normal. So it was like kind of puzzling for us as well. And we're also thinking the same way what Dr. Dhaliwal is saying, that where is this albumin losing? And to give you the perspective, like we obtained serial UAs, we did like multiple urine protein create ratios, all of them within the normal limits. So that was not a concern that she is losing it in the protein. And we were also thinking that just given the weight loss, first we need some kind of imaging. So we got the CT chest, abdomen, and pelvis. And maybe I will share my screen. And okay. So I have two images. It's like just the screenshot. It's like
Yep.
not the scroll down, unfortunately, but let me show you the first.
Okay. The stomach seems like it's full of some fluid. Maybe it depends where the person is in the eating cycle. The possibility of sort of compression of the outlet of the stomach. Stomach also, I hesitate to call this, but I'll just try and see what happens. I don't know if it's a little bit thickened. Sometimes you think something is thick on CT scan, and the radiologist tells you it's normal. So I've done that countless times. But I think the folds look a little bit pronounced there, so I might ask the radiologist about that. Um, and then just on the other side, I'm not sure if there's a heterogeneous mass that's sitting between the gallbladder and the midline. Maybe that I would require some description on as well. Kidneys look normal. There's no hydro to speak of. And I can't see the pancreas in here, or if I am, I'm missing it.
Perfect. That's spot on, Dr. Dhaliwal. I will tell you the official interpretation. Before that, let me share the second image as well.
Okay, so this stomach, here the stomach looks, if that is the entire contour is of the stomach on the left, I think that is a big pendulous stomach going across. And if it is, that speaks to one or two things. Either it's been obstructed for a very long period of time, is gradually dilating, or it's being infiltrated by something else. I think my commentary there is mostly on the stomach, which looks to be large, distended, and filled.
Yes. Perfect. So you're right. That is what they read it. So they said that looks like that there is rugal thickening. That's why they said that this is maybe just hypertrophic folds of the stomach. They were not able to comment on whether there is obstruction anywhere in the GI tract, a very focal point or not. They did say that there was a liver cyst, which was the homogeneous in nature, which is what we were seeing on that side, but they didn't comment much on it, so it didn't look malignant. So at this point in time, all we know is that this person has like some thickened gastric folds. So maybe Dr. Dhaliwal, you can share your thoughts on that. And then maybe I can also ask you a follow-up question that like, what would be some serological workup which you will pursue given that the albumin is low and we are still not sure where it is coming from?
Yeah, so maybe going to the morphology first. I think the general principle you ask is what is infiltrating the GI tract, right? Particularly the stomach. I don't know if there was thickening in any other structure, Kirtan. Was it just the stomach and nothing else?
Yes, they said just the stomach wall.
Okay, so if it's just the stomach wall, then I mean, you think in the same general categories, but in generally infiltrative disorders, we oftentimes ask ourselves, like, are there slow-moving cancers or infections that can take up residence in this way? Sometimes we try to see if there's inorganic substances that can deposit in certain tissues. Are there pure elements alone, like that can do this? I think here your attention probably will be focused on malignancies, and this is because of her age and weight loss and such. And if we just started with the basics, I don't think we should get exotic. The major considerations when you have the stomach is whether someone has gastric adenocarcinoma, which can show up as a mass, it can show up in an ulcerative form, it can be an infiltrative form called linitis plastica. Lymphoma can do this. When we think about lymphoma in the GI tract, the two places where lymphoma shows up the most is the ileum and the stomach. So I think those would be important considerations as well. Neuroendocrine tumors are possible, but I think are less likely in this category. They oftentimes are adjacent from the pancreas, but they can arise there. And we learned about maltomas, which sometimes are H. pylori associated. If it wasn't those categories of illness, that is to say, cancer, you might say, what infections take up shop? Not landing on it and just irritating it in the way that H. pylori might, but really in an infiltrative fashion. I think worldwide, probably the leading candidate would be tuberculosis. People may or may not know, but before respiratory specimens were used for sampling and diagnosing tuberculosis, oftentimes gastric aspirates were done. I think in pediatrics, sometimes that is still an approach that is done. So TB can set up shop in the abdomen. And then if one were to think of other sort of infiltrative disorders, it's not as common that the cells that we worry about infiltrating other organs, this is mastocytosis, histiocytosis, the granulomas of sarcoidosis, even amyloidosis, infiltrate the stomach with great frequency. There is eosinophilic gastritis among all of those that I might consider more, but those cellular-based infiltrative disorders I would have as a more distant consideration. Essentially, histology would probably have to lead me to them rather than a priori looking at this CT scan, particularly because, at least to the best of my knowledge now, there's no other abnormality in the chest, although we didn't see a chest x-ray or the abdomen.
Perfect. So just to round up the other imaging, Dr. Dhaliwal, like CT chest was fine and there was no evidence of infiltrates, lymphadenopathy or pleural findings. And similarly for abdomen and pelvis, the only finding was this gastric rugal thickening. There was no evidence of any mesenteric lymphadenopathy. And as you said, we need histology. So we pursued the EGD. But
And Kirtan, can I
before,
just confirm that
Mhm.
the pancreas
Yes,
was normal?
yes, that's correct.
Lipase
Yeah.
and morphology and no risk factors in the
Mhm.
past, like alcohol and such.
Oh yeah, sorry, I should have mentioned it earlier. So this patient's family history is non-contributory, nothing wrong there. Social history also completely clean, like no alcohol, no smoking, no cannabis, no over-the-counter medications. Health-related behaviors, patient is born and brought up in St. Louis, never traveled anywhere else, no recent sick contacts either. Patient doesn't have any allergies. So just rounding up that workup. And yes, the pancreas looked okay. And patient's other liver function findings like AST, ALT, LDH, bilirubin, alkaline phosphatase, GGT, all within the normal limits. Regarding the EGD, before I give you the EGD, I wanted to ask you this, Dr. Thaliwal. Any serological workup that you would pursue for possible protein-losing enteropathy? Although I know we don't have enough signs and symptoms going on in that direction.
Yeah, protein-losing enteropathy is a secondary diagnosis. That is to say, there's always something that is underlying it. And in young children, there's congenital lymphatic disorders. In adults, it fundamentally comes down to the question of what is infiltrating the mucosa or what is infiltrating the lymphatics or interrupting the lymphatics. So it winds up being similar to some of the suspects that we already mentioned above. There's no serologies per se for lymphoma. You might start to think about conditions that are immune and therefore might have a secondary degeneration. For instance, celiac disease rarely can have a degeneration to that, which I believe is a T cell. If I remember correctly, I think it's a T cell. It's an unusual form of lymphoma that arises in the proximal duodenum and easily could extend to the stomach. So celiac disease would be a reasonable consideration very late at this onset, but sometimes it's unbeknownst to us. I think there is an autoimmune enteritis that exists, and you can get anti-enterocyte antibodies. It would be a bit of a long shot to say at age 80 this thing showed up all of a sudden. And so I think I'm trying to think of other serologies that help us get at mass formations or sort of anatomic abnormalities there. So perhaps celiac disease would be a consideration. You might do H. pylori testing has been mentioned, but it would really only be material if it somehow led to a malt lymphoma in this case. I don't know the other connections. It has rare other connections, but that would be the most probably significant consideration now.
Perfect. Awesome. So to give you the basic workup, like although the CBC looked okay, the basic nutritional workup was pursued like B12, folate, all of that within normal limits. Ferritin was fine as well. Vitamin D was within normal limits. Vitamin K was within the normal limits. As part of the producing enteropathy workup, they did get the celiac serologies. So anti-TTG and anti-gliadin, both antibodies were high titer positive.
Mm.
And then to further figure out that what's going on with the gastric rugal thickening, and now the serology has been positive, they obtained the EGD, which showed that there was foveolar hyperplasia in prominent gastric folds. There was no evidence of H. pylori, and no neoplastic cells were seen. When they did the duodenal biopsy, they found that there was duodenitis, active duodenitis with neutrophilic infiltration and villus atrophy. So at this point in time, the GI said that based on the morphology and the histology, this is consistent with hypertrophic gastropathy and celiac disease. And I would stop there before giving more data.
Okay. Yeah, this is I think a couple things warrant comment. One is it's surprising that the rest of her nutritional assessment, to the extent we can do it, is normal. Now, I think sometimes when you consult in nutrition, they'll also test for a lot of micronutrients, and a few tests don't define it, but it is striking that she's replete in all those areas, which is good news. I think we have to turn our attention. The EGD, I'm sorry, this is just the anatomic approach and then the biopsy results there, correct? Um, so I think that we have to go through this. I must say, one of the things that when you try to say, how do you socialize yourself into medicine and you learn how to reason like a doctor, it oftentimes goes back to a very classical education, which is you are trying to learn. You imagine when we teach trainees, we're basically trying to teach them in the art of vocabulary, how we talk like a doctor, logic, how we think like a doctor, and then finally rhetoric, how to speak and write like a doctor. Those things together are sort of what makes the foundations of a professional. And so the foundation, of course, is learning vocab. And I must say, the one thing vocabulary and logic and rhetoric all go together is I have forgotten, I think I remembered at one point, but foveolar hyperplasia, I don't remember what the adjective foveolar means. So is that a giveaway, Kirtan, or can you translate
No,
that for me?
no. It's not given, Dr. Dhaliwal. I could tell you. So foveal hyperplasia, basically, they just meant that the gastric glands which secrete the acid, that is just hyperplastic. That's the foveal hyperplasia, nothing else. Yeah.
Okay. I mean, there's always a consideration when we have hyperplasia. Thinking about the glands, probably takes me back to biochemistry. Thinking about the glands, if there is something that is driving the production, that is to making it proliferate. For instance, I'm going to ignore the celiac sprue for celiac serologies for a second and say, what if what could be driving the hypertrophy? Sometimes you will see this an excess of gastrin, for instance, and people have Zollinger-Ellison syndrome. This can lead, because it's trophic to the gastric lining and also leads to hyperproduction of acid. That can lead to thickening. And so now I have some interest in maybe grabbing a gastrin level, particularly before we start PPIs or anything else for this. H. pylori absence is helpful. Neoplastic cell absence is helpful. I will note there are a number of cases where gastric biopsies are done, including the gastric outlet, and this malignancy is not caught because they are superficial. And then what has to be done on repeat is either the gastroenterologist or a surgeon has to do what's called a deep biopsy. So I've learned that it's good news that there's no cancer, but it doesn't mean that there isn't here. And I can't do this. And then the one other thing with the duodenitis, I have to check my reminder of that, but duodenitis with villus atrophy is very characteristic of celiac sprue and other sprue syndromes and even things that destroy the architecture. The neutrophilic infiltration, my recollection is sprue is more apt to have a lymphocytic infiltration. And I would have to check that. Perhaps it comes in both varieties, but I know it to be more of a lymphocytic disorder. So that would be, I'd check what foveolar means, but Kirtan explained it to me, and then I would double check the expected serology the histology in celiac disease, wondering if the neutrophils at all is a clue that it's reacting to something else. And then finally getting down to the serologies, having two of the serologies being positive is very specific for it. They're quite good tests. And I don't have on speed dial a number of reasons that you would have false positives for this. At the same time, I have to mount a bit of healthy skepticism to say someone would be seropositive their whole life and suffer nothing from it until this moment. And so it still makes me wonder if these things are being elaborated. Is it because our immune system has been activated by something like a lymphoma, for instance?
Perfect. Awesome, Dr. Dhaliwal. So let me give you how the case progressed. That at this point in time, GI said that we are convinced that this is hypertrophic gastropathy and celiac disease. They said that the secondary workup for hypertrophic gastropathy includes histology, which we did, and they were not able to find any infiltration. They did consider what you said, that can this person have Zollinger-Ellison syndrome, although they would classically expect some degree of ulceration in either stomach or duodenum. They didn't see it, or maybe some degree of diarrhea as well. But still, they obtained the serum gastrin levels, like the fasting serum gastrin, when not being on PPI, and they were within the normal limits. So they said so many people can have idiopathic hypertrophic gastropathy, so we don't want to do anything. For the celiac, they just said just do gluten-free diet and then see what happens. And also, like to round up other differentials which were mentioned in the chat, that at this point in time, they also ordered the CT angiogram, like with different kind of vascular protocol to make sure there was no like occult mesenteric ischemia, but there was no concern for any vascular compromise anywhere. So patient was started on gluten-free diet, but unfortunately, despite being on gluten-free diet for 4 months, the symptoms didn't improve. And this is like we talked to the patient multiple times, and we made sure that patient is adhering to the gluten-free diet, they're maintaining the food diary and everything. So there was no concern about the lapses or like some occult gluten in some substances. It was clear that she knows what's going on. And despite adhering to gluten-free diet, she kept on losing weight. Now, when she comes to the second time to the hospital, the symptoms have not changed much. She's still not having diarrhea, still not having nausea or vomiting, just some postprandial abdominal pain, but she kept on losing more weight. So now we are talking about total 35 pounds of weight loss since the illness began. And now she had two other symptoms which came up, and also one another lab abnormality. So I will mention all of them. So I was examining her. Like this patient got admitted because of the concern for failure to thrive. And the reason for admission was just G tube placement. So I thought that, okay, it would be easy admission. I just went because she was not eating anything. So they thought that let's just put G tube. So I was thinking it would be easy admission. I went there to check, and I looked at her hair, and her hair seemed little bit less profound. So I asked her that, has your hair always been like this? And she was like that, no, my hair used to be more thicker, but over past 2 or 3 months, it seems like that I have been losing them slowly. And I did ask that, do you think you are hurting in the scalp? Is it painful? You are having itching there? And she said no, that it is painless. I looked at the scalp. I couldn't see any erythema, couldn't see any signs of like blood crusting, no evidence of tinea infection. And it was clearly painless, non-inflammatory kind of hair loss. Then I looked at her nails, and I couldn't see nails. All I see was nail bed. And I'm like that, what happened here? That, and she again told me the same thing, that she doesn't know what happened. There was no new creams, no new like detergents that she used, but slowly, painless, she lost all the nails. And in her labs, the new finding was that the AST ALT was still fine, but the alkaline phosphatase level was like low. It was like I can 25 or something. And albumin stays low as well. Albumin was like 2. And other thing I would say is yes, everything else seems fine. CBC is okay. Rest of the liver function is fine. Apart from albumin and low ALP, everything was within the normal limits. And regarding her anorexia, I again asked that, what is the reason you are not eating? If it's not pain, then what is bothering you? She says that she's just not having the taste sensation. She's just having anorexia. That is why she is not eating. And I would stop here.
Okay. Yeah, there's a substantial turn, and sometimes we have to let disease take its course. I want to come back to GI's impression, but let me work backwards. I think if when people have hair loss, oftentimes it relates to there is an age-related decline in hair loss. I'm the last person who should speak about this topic because I have no grounds to speak out regarding hair integrity. But there is age-related hair loss that happens over time, and so there's a natural thinning, so we can't pathologize it overall. But we do wonder when there's non-scarring alopecia, that's to say there's no dermatosis to spin it to explain this, right? The skin itself is not abnormal. There are sometimes systemic disorders like syphilis. This has been tested and it doesn't seem like it's a leading consideration. There are metabolic considerations. They oftentimes relate to a number of nutritional deficiencies, and zinc is one of them among many, but oftentimes it's not the zinc is responsible, it's that the person is malnourished. The fact that the ALK phos is low, that maps on to mostly it maps on to one finding in medicine that I'm aware of, which is the person has zinc deficiency, because zinc is responsible for I think it's a cofactor in the generation of this. You sometimes see this in Wilson's disease also, similarly a low ALK phos because of the interaction between copper and zinc. And so you ask yourself, maybe there is a zinc deficiency that's going on, and if there's zinc deficiency that's going on, we still have to ask why we've gotten to this point. There is a syndrome that comes to mind now because she has this integumentary findings, that is to say, skin and nails, and the GI tract, and I think it goes by the name of something like acrodermatitis entropathica. It is adjacent to zinc deficiency, and I forget which way the direction goes. I think zinc may be causal for it, but it would start to make me think of syndromes that might be explained purely on the grounds of zinc deficiency alone. Although we'd have to ask what is it about her that prevents her from getting it, because it's an unusual thing to have by itself. Yeah, check that in the chat. Don't you might have to strike that from the record if that's incorrect. But I think now we have something to go on. Although I have to say, coming back to the thickening and the autoimmune serologies, which I think now may be false positives. If someone is truly adherent and doesn't respond to a gluten-free diet, and I know it's extremely, extremely hard to do, but if they truly don't, by all measures, I think that calls into question the diagnosis of celiac, because we already have so many other reasons to question it, like the onset at age 80. Even when we learned of it as being not a pediatric disease, but something that could present throughout life, and no one has ever fashioned it as a geriatric syndrome. And so that's one thing that I still think like something else is stimulating her to elaborate those antibodies, perhaps because the number of antigens are being revealed from this other process that she has there. So, I mean, I'd probably go back and see, is there any reason to believe she might have zinc deficiency? There also could be a vicious cycle. She might be malabsorbing zinc from the original thing, and now it's sort of whatever the original process is, and now she is in a doom loop where the zinc itself is the absence of zinc is toxic to her body, but the primary problem, like a cancer, is still unsolved.
Perfect. Awesome, Dr. Dhaliwal. So I also thought the same, that she has hair loss, she has this nail loss, all painless, and TSH, syphilis, B12, renal function, like the other common findings are normal. And at some point, they even got the ANA just to make sure, because
Yeah.
she already has one autoimmune process, right? So they got the ANA, which was fine. They got the anti-goblet cell antibodies. I think that is what Dr. Dhaliwal was saying earlier about anti-enterocyte antibodies. So that is for autoimmune enteropathy, it would be unusual, but we got it, which was unremarkable as well. And then we got the zinc levels and copper levels. So actually both zinc and copper levels were low. And that is the only abnormality which stood out. And even at this point, the repeat TTG serologies were still positive, both high titer IgA anti-TTG positive. And LDH levels were again normal. So we were not sure that what is wrong. So maybe I can ask Dr. Dhaliwal at this point that what would be the next step that he would do to figure out that why this person keeps on losing weight, has anorexia, has this like zinc deficiency, but from what we don't know, and what would be the next imaging or serological study?
Yeah, so I think the zinc and copper, they have some interaction with each other. When people are hypocopremic, they can get then zinc. I have to remember the directionality of it, but I think they can get zinc. Oh man, it's a little complicated. I think when they use zinc supplements, that for instance, zinc excess, maybe I'll think this out this way. When people have excess zinc, like for you often see, not often, but one scenarios where they use it in their dentures, etc., that leads to hypocapremia. When the two are together, I don't think it works. I don't know of a bidirectionality when they're both low. I might think that is still a marker of just micronutrient insufficiency. Speaking again to the idea that she's sort of malabsorbing in a way, just like her perhaps low albumin suggests as well. I hesitate to staunchly say she does not have celiac disease when the antibodies are positive, but I think this is a good example of them. They're not falsely positive in the sense that's a lab error. The lab has proven itself twice. It just may not reflect the underlying disease, or it may not reflect the simple version of it, which is it's not celiac disease itself, but it's celiac disease that has transformed into lymphoma, as I mentioned. The other thing we should at least do to think about this as we have sort of inflammation in the duodenum is to say, are there other conditions that are infiltrated in the duodenum that we didn't think about and require specific staining? They're not routine things that the pathologist would do. And some of these are worth mentioning. They are staining for the cells that I mentioned, like eosinophils and histiocytes and mastocytes. Those would probably be done. Flow cytometry can be done, some of the testing. For amyloid, specific staining needs to be done. And I think now would be a time to do it. And even PAS staining for Whipple's disease, for the idea of something that set up resonance, caused a neutrophilic infiltration. Whipple's disease sometimes mimics other conditions. It can have an arthritic component, so sometimes it's a mimic of RA. But I think I would at least, if we get a new sample, of course, be a deep sample, be vigilant for the cancers that we're looking for, lymphoma and carcinoma, but also think about the extended spectrum of stains that I'm talking about that I just mentioned.
Perfect. So no, you are spot on, Dr. Dhaliwal. We're also thinking the same thing, that maybe she does have celiac disease. Why? We are still not sure. Maybe she is not responding because, as you were saying initially, there is this unique variant known as enteropathy-associated T-cell lymphoma, which can develop in people with celiac disease. And it's sometimes very hard to catch because what if this is in the jejunum or maybe ileum where even your scopes cannot reach, right? So
Yeah.
at this point, the decision was made to redo the imaging. So the repeat imaging was done, the CT scan of the abdomen pelvis with contrast. Again, everything else apart from stomach looks okay. No lymphadenopathy, spleen looks fine, liver looks okay. The other bowel loops like the colon, jejunum, ileum also looks normal. But the stomach keeps on getting more and more worse. So there was now extensive mass-like thickening of the stomach. And there was suggestion that there might be some polypoid lesions there, which were situated near the antrum, causing gastric outlet obstruction. So at this point in time, since the suspicion was so high that maybe there is a malignancy which we missed, they repeated the colonoscopy and EGD both. So colonoscopy was unremarkable, nothing they could find. In the endoscopy, this is what they found, that multiple gastric polyps almost obstructing the entire lumen of the stomach and gastric outlet, erythematous mucosa, and duodenal villus atrophy in the duodenum. And I will just leave it here at this point, and I will let Dr. Dhaliwal speak what it could be, and then I will give you the histological findings in this, and then I will give my slides and we will end the conclusion.
Okay. So I think the biggest twist, not twist, but important interval information is that no disease has shown up outside the stomach now. We are still in the same place as we were before, meaning no lymph nodes has shown up, no ileal disease, things that might move us more strongly towards lymphoma. It is unusual, just to say, in gastric adenocarcinoma or gastric lymphoma not to have local lymph nodes, particularly, I think they call them stage D1, D2, but local lymph nodes are very common because of the extent of it here. So I'm struck a little bit by the absence of lymph nodes. Is that correct, Kirtan? There's no lymph nodes? Yeah, so a bit unusual for either one of those forms of cancer to not drain in the regional lymph node beds, let alone spread when it's been going on this long. And then the second thing that I think is, and then the duodenum, I know we've been talking about the stomach. Is the duodenum abnormal on CT, or is this really just the stomach is abnormal?
Right. So sorry, I forgot to mention it. So this time when they did the repeated EGD, even in the duodenum, they found that there was this polyps. So these polyps are everywhere now, stomach as well as duodenum, but otherwise the mucosa seems okay.
The other thing that's unusual, I must say, is polyps showed up since the last scope. Is that right? It was not seen on the first one? You know, when we have polyposis syndromes, they exist, like hereditary polyposis that shows up in the colon, particularly sometimes in the small bowel. There are things that are trophic that drive polyp development that you might see more frequently, like what's a good example? Like excess growth hormone or acromegaly. Sometimes those patients are more prone to polyp formation, just like they are to other tissue proliferative findings in the body. But you really start to get the sense that this disease just lives entirely in the stomach. And so, what sort of things lead to hypertrophy of the stomach and stay there and are not malignant? I don't want to give up on the malignancy hypothesis because I think it's very important here, including the T cell variant or the T cell version that arises from celiac disease. Although, to be fair, I think that thing is dominantly in the intestine, not something that invades the stomach to the degree that it does. Is it possible that she has a polyp syndrome of the stomach? There's only one I know of. which is the Cronkite syndrome. It sticks in my mind. For those who don't know, there's a very famous news anchor from CBS. He was in the 70s, 80s, or 90s named Walter Cronkite. And he was such an iconic person in U.S. history that I remember his name. And that has gastric polyps associated with it and thickening associated with it. I'm at a loss for remembering the pathophys behind it, or even if it can show up in someone at age 80. So I would have to go back and say, like, is the Cronkite syndrome, which is there, and then I mentioned the other one that I know, which is Zollinger-Ellison, but that leads to much more thickening and ulceration than polyp formation. I'm very struck by sort of polyps popping up out of the blue, which makes me wonder that with such an odd histology pattern, that's usually driven by a genetic abnormality rather than an exogenous hit. But I cannot explain why that would turn on at age 80. So what would I do now? I would still do the deep biopsy, still hit stain for all the unusual things that we're talking about, and then go from there and probably do a little bit of reading.
Perfect. So no, spot on, Dr. Dhaliwal. So what happened was that they got the biopsy and they stained for B cells, T cells. They did the T cell rearrangement studies. They did the monoclonality studies. They even did the PAS staining, all of which unremarkable. They did the AFB staining, the Warthin steri silver stain to look for like weird organisms which could be sticking around in your
Yeah, fair
mucosa.
enough.
All of right. So all of that were normal as well. Nothing there. And the biopsy showed that what they found was inflammatory or hyperplastic polyps, and there was prominent lymphocytes, plasma cells, eosinophils, and neutrophils in the polyps as well as in the intervening mucosa as well. So basically, everything which the biopsy had lymphocytes, neutrophils, and eosinophils in equal amounts, and no clonality was detected, and no malignancy or dysplastic cells were seen as such. So this is the final record, and now in the next part, I will reveal the diagnosis.
Okay. So just to be clear, there's sort of a symphony of cells have been drawn to these polyps and the surrounding mucosa, but they are non-malignant by almost every measure we can find. The flow and histology and staining and things of that nature. Then, um, as much as I try, I think it'd be very hard now to continue to hold on to the hypothesis because you'd have to imagine the thing that's thickening the stomach is also the thing that's causing the polyps. It'd be a remarkable intellectual feat to separate the two because it seems like these polyps are an end stage of the hypertrophying process that's happening in her stomach. And so I sort of shift categories. You sort of now start to think, well, what category could I be in? And I mean, is there a cancer? Well, I wanted it to be a cancer, not for her, but for intellectual coherence. But I just cannot find evidence of it anywhere, and it's not acting like it in any other way. Could it be an infection? Conceivably, but she has no reason to be at excess risk for anything exogenous based on what we know and what's been studied. And so I started shifting my ideas to sort of think categories like autoimmunity. And even autoimmunity, I think even when you get to that category, you have to still put yourself in one of the subgroups of autoimmune disorders. Is this something like the ANA positive disorders? Is this RA, Sjogren's, and that subgrouping? Is this a seronegative spondyloarthropathy? Is this vasculitis? Is this part of the myositis family? And I have to say that this a unique focus on the stomach in an infiltrative way is not characteristic of too many of them. As I mentioned, there are some infiltrative disorders, maybe as a third category, like eosinophilic gastritis that does this. But I might find myself saying that because I can't put an immune system on this, it may, again, that Cronkite syndrome I mentioned, it may be that physiology has been turned on for reasons that are uncertain to me. And this is what she's manifesting, because that does have the thickening and the malabsorption as part of its picture. What I don't know if even that is the right hypothesis is what it is that I think it might be a genetic test, but I don't know exactly how one proves or disproves that hypothesis.
Perfect. So, Dr. Dhaliwal, we have got a diagnosis already, so we are certain of that. Now, let me share my final
Meaning
slides.
you have gotten the diagnosis, or I've
No,
gotten
no, no, you. I think you have already gotten the
At least it's been
diagnosis.
mentioned. That's good.
Yeah, yeah. Perfect. All right. So, you guys can see my slide.
Oh, the M leaf. Should I try to decide? Is there
Yes,
a
please.
way to try to think of M leaf? Like the leaf, leaf is associated with cancer. There's sort of I'm trying to think of medicine motifs that last with a leaf. This is kind of the sideshow here, but um uh you could be sort of leaf things. There are some things that sort of have a leaf-like distribution, like evergreen patch. All the tree-related findings in medicine. Um, there's maple leaf, which sort of has a Canada diagnosis, which is Canada is actually that Cronkite syndrome is actually called Cronkite-Canada or Canada Cronkite, one of the two. That may be part of it. Um, but yeah, or if leaf is suggesting something else, we'll see.
Yeah, perfect. So I think you got it, Dr. Dhaliwal. So let me go to I just summarized some data that what were the salient features of the case, that we have the prominent gastric folds, we have duodenitis, and most importantly, we have the inflammation in the polyps, but it is present in the intervening mucosa as well. This is very
Yeah.
important, that you can have polyps which are inflammatory, but the intervening mucosa should be clean. So the fact that the intervening mucosa also has inflammation is very telling. And then patient has onychodystrophy, patient has alopecia, patient has protein-losing enteropathy. So this is the hypertrophic gastropathy slide, that what are the
Mm.
common causes. So we talk about Menetrier's disease, which is driven by TGF alpha. So sometimes people give TGF alpha blockers in Menetrier's disease, but that has to be diagnosis of exclusion as a way. Zollinger-Ellison syndrome, and what are the features of protein-losing enteropathy. So we didn't see almost any of them apart from hypoalbuminemia, which was kind of surprising. Then what are the etiologies of hypertrophic gastropathy? So some infections, we checked for all of them: HIV, CMV, H. pylori. The cells, which Dr. Dhaliwal mentioned, that you can have amyloid, you can have mastocytosis, you can have eosinophils. We stained for all of them. There was no monoclonality or clear dominance of one of them. Some neoplasm, so we did the deep biopsies as well, so as to not miss adenocarcinoma, lymphoma, or carcinoid tumor. Then what about onychodystrophy and alopecia? So we know that there is some kind of damage to the ectodermal structures. Either can be directly from the underlying inflammatory disease, or it can be from the nutrient deficiencies like zinc and copper. And since zinc is a cofactor of alkaline phosphatase, low ALP can point to that. So like kind of nice teaching point right there. And then what about the protein-losing enteropathy? That this is the rough landscape, that you could categorize it as erosive mucosal disorders, which could be like IBD is the big one, then non-erosive, in which SLE is the big one. Then some lymphatic disorders, because we know that lymphatics play a crucial role in absorption of nutrients. So if your lymphatics are dilated for some reason, you can have protein-losing enteropathy. And in the lymphatics category, the Whipple's disease will also fall. In the infiltrative, we already talked the same thing, which can infiltrate your stomach, can infiltrate your intestines as well. And then finally, polyposis syndromes, that juvenile polyposis, Pews-Zager, Gardner syndrome, Bunyan-Rubalcaba syndrome, right? So what happened that night was, it was so funny that I had a medical student with me, and I was like, G-tube, very easy, should be done in 30 minutes. I went there, I checked, and I was like, what happened to these nails? That I don't care about zinc. Your zinc can be low, but these nails should not happen. And then I asked them a bunch of questions. All they said is they have hair loss. And then I was telling my med student that, you know what, that you must have remembered this in the pathology, like that there are all these polyposis syndromes. Do you think this could be that? And he was like that, yeah, sure, it could be. Let's look it up. And I'm like that, yeah, there is one syndrome. You should look it up and let me know. So he looked it up, and then he came back after 1 hour, and he was so excited that, oh, Dr. Patolia, could it be this? I'm like, let's try. So I texted the GI people overnight, and GI is like, patient is too old and patient is here for G-tube. Why are you thinking of all these syndromes at night? I'm like, well, patient is 80-year-old. We don't have an answer. So maybe we should run it. And they said that, yes, if you think it is the case, then we will do the EGD colonoscopy, because they were just going to do the G-tube. They were not even concerned about EGD. But then I convinced them that, hey, let's do the EGD. And then they found these polyps, and they found the characteristic eosinophils, lymphocytes. So you even predicted it, Dr. Dhaliwal, that this was the reason, the M leaf, that M is the maple, maple is in the Canada, right? So the diagnosis is the Cronkhite-Canada
It is a
syndrome. So
grind.
yeah, so you guys got it. And just a very important reminder that why this syndrome is important to diagnose. That all other syndromes, Peutz-Jeghers, Bunyan-Rubalcaba, Riley-Cowden, are genetic in nature. Cronkhite-Canada is non-genetic in nature. If you think that, what's the point of diagnosing this? It's just a fancy name. You will just remove the colon, you will just remove the stomach, you will do polypectomy. But that is where we are wrong, right? That Cronkhite-Canada is actually an immune-mediated disorder, and it does change the management. You have to give them steroids, you have to give them cyclosporin, azathioprine, and in fact, if all those don't work, you actually have to give TNF-alpha inhibitors. So imagine giving TNF-alpha inhibitors for polyps. It's kind of unusual, right? So that's why it's important to diagnose this condition, because it does change the management. It's not just about giving someone a fancy tag. but patient's life can change, right? So it is considered to be autoimmune, which causes this chronic inflammation, which eventually spills into your nails and hair. It can mimic the hypertrophic gastropathy and Menetrier disease. And as I mentioned in the last line, that the key histologic feature is you need to have these inflammatory infiltrates both in the polyps and in the intervening mucosa as well. So this is a treatment that if there is H. pylori, you treat it to give the acid suppression. If doesn't work, then start with the steroids, then go to azathioprine, cyclosporine, and then the TNF alpha inhibitors. And you can supplement the nutrients as needed. So this is the part to the puzzle that you started with polyposis, then there is eosinophilic inflammation, there is proteinuria enteropathy, there is onychodystrophy alopecia. And regarding the celiac part, so this is the most insane part of the case that I talked to GI people and they said that this person has celiac for sure. The reason why she didn't respond to gluten-free diet is because they have Cronkhite-Canada syndrome on top of it. But those villus histology and everything, they said it is very consistent with celiac. And those high titer antibody positive are not seen in any other condition. So they were like that this person is so rare that she developed both celiac and Cronkhite-Canada at an unusual age, at the age of 80, when both of these disorders should come early. So she did indeed have both of them. There was like no concern that it was not there. So yeah, very unique case, both Cronkhite-Canada and celiac disease at the same time. And you got it, Dr. Dhaliwal. So
Wow.
happy.
Yeah, I forgot the name. So first of all, Kirtan, I think the next time someone is admitted for placement, they should be very careful if they're on their service because they'll probably get the workup of a lifetime. You and your student did this person a tremendous service. Could you go back to the second to last slide, that sequence of events you had, just to
Yes.
point out, and I'll make some commentary. I think what we had there is very close to what we try to do, which is now, there's many ways to sort of enhance our reasoning. One of them is to update our knowledge structures. How good is my schemas? How good is my illness scripts for things? And as you have a library of those, you can put them together. But another thing, getting back to the other principles of reasoning I talk about, which we socialize ourselves to know vocabulary and rhetoric and logic. The construction of rhetoric and logic means like I have a compelling sequence of events that happened here. And I think what this you're describing here is your sort of journey on it. Is that right? Because I think if we were to invert this in terms of the theory of the case, it would be that she has this syndrome, Cronkhite-Canada exists in her, or some latency for it, right? And then that drove the development of this gastric inflammation. Um, and then that gastric inflammation led to the protein-losing enteropathy, and the low protein-losing enteropathy had, as one of its side effects, low zinc. That led to the integumentary or ectodermal abnormalities. Correct? Is that the sequencing of events? I think this is the intellectual journey, but in terms of if we reversed it, um, is that the right way you're thinking about it? Not that Cronkhite-Canada syndrome makes you lose your hair or nails, but it's the zinc deficiency it induces through PLE. Correct?
Right. Yes. And actually, Dr. Sariwal, a little bit of both because some people believe that even if zinc is almost okay, people with Conquer Canada still end up getting this hair loss because of the inflammatory nature as such, because they were saying that other polyposis syndrome who also have zinc deficiency do not develop hair loss to this much extent. So they were saying that maybe it is multifaceted, that the inflammatory nature itself directly hits your ectodermal structures on top of being deficient in zinc.
I see. Okay, so there's some overlap. And then two other comments. One is I think you emphasized the same thing that I was at the end, where I really couldn't classify this in any category. I said, this is not malignant, this is not infectious. I even hesitated to call it immune. But the one thing was the notion that the mucosa was infiltrated with the same thing that the polyps had, which I think you also emphasized. And to me, that sort of had a sense of like, this is like calling all inflammatory cells, right? They're all being summoned for some reason. Instead of thinking that changed my thinking, instead of, aside from it being just unusual for polyps to show up out of the blue, even in a secondary nature, I think it's pretty unusual. But really, then you just had to gather like what on earth could call all those inflammatory cells to the mucosa. And then that being essentially, you can call it, it falls under autoimmune if there isn't anything more fundamental, like a single genetic driver of that or a single environmental trigger of that. And again, it's funny why you remember these things. I've never seen this case. I have seen NEJM CPCs from time to time on it, but maybe just showing my age because it had the name attached to it, not Canada, but Cronkite. Cronkite's an unusual name unless you know this really iconic CBS broadcaster, he was a fixture in American homes for much of the end of the 20th century. And so when I saw a name like that many years ago, of course I knew it wasn't him, but I said some lucky fellow or person carries that same name as he does. And the polyps was the only part I remembered. What is the pathophys then? Is there a genetic predisposition to this that they have, or?
So they were saying that it's like polygenic. So there are multiple genes which are involved, and they were saying they are in the same family as APC. So like the one which leads to familial adenomatous
Yeah.
polyposis. And they were saying that downstream signaling pathways includes like nuclear factor kappa beta as well as the interferon signatures. So all of them combine and cause all this polypoid growth. And they haven't been able to pin down one gene, so that's why it is still polygenic. Yeah, but it is
Polygen.
like just like acquired. They say that's why it comes very late compared to other syndromes. Yeah.
Yeah, I don't remember if the cases are this late. Though again, few I've read, never seen. And then the last thing is that maybe I'll invite you. Do you believe she also had celiac sprue, or do you feel like if the autoimmune system is been activated, that she can fire off serologies that are off target essentially?
I was also grappling the same question, Dr. Dhaliwal, and I looked it up also. But to be honest, like this syndrome is so rare that there haven't been like any reports of concurrent celiac disease with it, and that's why I even talked to our GI specialist. And our GI specialist was saying that the fact that we got Cronkhite-Canada itself is a big deal because we were not even thinking of Cronkhite-Canada. It's just that like you brought it up that oh this has onychodystrophy, alopecia. That's why we got it. But celiac, we are not sure how it could be linked. But even as of today, she's still on gluten-free diet because
Hmm.
they are not comfortable putting her back on the normal diet. But she is doing well. Like she was started on steroids and she was also started on cyclosporine. And with both that, she has gained weight. So she gained like 15 pounds of weight back and her hair is slightly coming back. So hopefully we are in the right direction.
Yeah. I mean, I don't know how much this is open to dialectic and pro-con arguments, but a gluten-free diet is a substantial curtailment of what you can eat. And so it must be possible. All serologies have false positives, and we have spectrum bias. That is to say, when we learn about how serology performs in a very normal population, whatever that is, or typically symptomatic population, it may have these incredible sensitivities and specificities. But the performance of it when the GI tract is disrupted in the way that it is now, right, with this syndrome, I bet you some immunologist or someone could theorize that there's a very high probability that those serologies are not pathologic in her. They probably thought about it much greater depth than I have, but I think I would be open to that possibility. And like it's so rare that no one can answer this. It's without taking her off the gluten-free diet and seeing what happens.
Yeah, perfect. Thank you so much again, Dr. Dhaliwal, for your precious time to be with us and showing how you think through this case, at what point in time you come up to the diagnosis. So I'm so glad that we are on the same track and we were able to give this patient a diagnosis. And the most important part is the M leaf. I was more excited about that. So we got the M leaf.
Yeah.
So
Well,
today everyone has to eat something which has maple in it, like maple syrup or like some cakes or something as a Christmas spirit. And this is the best way to enter the Christmas week.
I will never forget it because I remember the Cronkite part and I forgot the other part. And now I'll remember the Canada as well. So they're forged in my mind as well. Thank you for the
Of,
invitation. This was tons of fun.
of course. But
Thank you everyone for joining. If you want to take one thing from this is that it's all about deliberate practice. Gurpreet and Kirtan have read every single CPC from 1997. So if you want to get started, this is your sign to start. The time is now. Have a wonderful day, everyone.
Bye bye.